Hi everyone, welcome to Reform Subspecialty Neuro VMR today. We have amazing case presenter Sarah and our attending physician, Dr. Helen Shi, and Gerardo will be co-discussing with Dr. Shi. So please, Dr. Shi, Sarah, and Gerardo, please introduce yourself.
I can go first. Hi, I'm Sarah. I am a medical student from Emory. I am planning to apply to neurology residency this summer, and I'll be presenting the case.
Oh, Dr. Shi, you want me to go first, or should you go first? Second, sorry. Oh, in that case, I think I can go second. Hello everyone. My name is Gerardo Luna Peralta. I'm a medical student, and I'm in my 6th year out of 7 years of training here in Peru. And this is my second year here in CP Solvers, and this is my first time in Rafael Medina's subspecialty series. And yeah, I'm very enthusiastic about neurology, so I'm really happy to be here, although I'm very nervous and also excited for Sarah's case. Yeah.
Dr. Helen Shi, would you mind introducing yourself also?
Sure. Hi, everybody. My name is Helen Shi. I'm one of the inpatient neurologists and neurohospitalists at Emory University Hospital in Atlanta. I got involved with clinical problem solvers maybe like 6 months ago, and it's been great. I think this is my 4th session. I've met some really great people, and actually one of our like very involved people in clinical problem solvers, Vale, I think is going to come rotate with me next month. And so it's been a great community.
All right, then we are ready to start. Sarah, would you mind starting from the chief complaint?
Yes, I can. This is aliquot number 1, chief concern. 60-year-old male with history of osteosarcoma, hypertension, hyperlipidemia, who's presenting with headache and double vision.
Oh, wow. What a great case. So Dr. Helen Shi, how would you start thinking with a patient presenting with headache and double vision?
Yes, this sounds like a very common complaint that we'll see in the emergency department. I have questions about like where was the osteosarcoma and how it was treated, but also certainly about the presenting complaints of the headache. There's so many headache questions to ask, but I think that the most pertinent ones are the onset of the headache, like the quality for how quick, like the feeling of the headache, but also how quickly it reached maximal intensity. And then the associated symptoms, which we're hearing about double vision, I want to know if it's binocular diplopia or monocular diplopia. Those are my big questions right now.
Oh, great. I think I can continue with the discussion. And yeah, this is something that really struck me first, because when I hear a patient with a cancer and also with neurological problems, well, I try to make a link between those two problems. And well, now the only link that I can make towards a possible link, it's osteosarcoma causing a metastasis and causing a neurological problem. And for that to be the case, I think we had to have a really we have to really have in mind the difference between monocular diplopia and binocular diplopia, as Dr. Shi said. And I think that it is very early in the case to really try to showcase explanations for those two things to happen, but some things come to my mind. For example, I know that double vision can be, for example, an impairment of the abducens nerve, and the bilateral, and if it happens bilaterally, it can be a non-localizing sign. and a non-localizing sign that appears in a patient with cancer, it can be due to hypertensive intracranial hypertension that can be triggered due to a mass processes. So that's the only link that I find so far, but I'm really excited to hear more about the case or more about Dr. Shi's thoughts about this.
Yeah, Dr. Shi, so how would you be your localization approach for a patient presenting with double vision from our neurology standpoint?
Yes, so for double vision, what's most important is clarifying if it's monocular or binocular. And so monocular means that the double vision is present in one eye. And so if you cover, somebody's like, I have double vision, and you ask them like when it's happening, have you covered your eyes, or let's do it right here if you're having double vision right now. So if you, they're looking with both eyes open and they're like, okay, things are double. I see them, side to side, or it's good to clarify, like, is it side to side? Is it vertical? Is it diagonal? And if they cover one eye and they say, okay, it goes away, then you want to cover the other eye and see if it also goes away. Then that would indicate that they're having binocular diplopia. So with both eyes open, there's some degree of ocular misalignment that might not be appreciable to us, the examiner, when you're looking at the patient or when you're checking extraocular movements. Like even just the slightest degree of ocular misalignment would cause a patient, like the person experiencing it, to notice the double vision, but to our eyes, we might not detect it, like seeing their ocular misalignment, but that would be binocular diplopia. But if somebody's like, okay, I see double with both eyes open, you cover one eye and they're like, oh, it's still present, I still see double right now, that would be monocular diplopia. If you cover the other eye, I'm assuming probably it's like normal vision, or maybe they're also saying that it's monocular diplopia, that they're still seeing double. That would be an ocular issue. That's not having any ocular misalignment, which would be when people have ocular misalignment, binocular diplopia, that would be an issue with one of the cranial nerves that control our eye movement, so cranial nerves 3, 4, and 6. Or it would be some issue with one of the muscles that control our eye movements that, the nerves innervate. So one of the rectus muscles, or like the oblique muscle. And then, or it could be a neuromuscular junction issue or a motor neuron issue.
Yeah. Oh, what a great discussion. Sarah, could you please continue history of present illness?
Sure thing. So 10 days prior to admission, Mr. X was awoken from sleep with a throbbing frontal headache not relieved by over-the-counter medications. He presented to his local hospital where imaging was performed, which showed no acute neurologic events. He was transferred to Emory, but discharged for conservative management of his headache due to no acute findings. One day prior to admission, he was awoken from sleep in the morning with frontal throbbing headache once again, but this time accompanied by blurred/double vision. He attended a telemedicine appointment with neurology, who encouraged him to go to the hospital with concern for, quote, eye stroke. His headache was resolved at the time of interval history. He had had multiple headaches in the previous 2 weeks and over the last 2 years, but this is the first time he's ever had double vision with his headache. Headaches are worse at night, and they're generally better with acetaminophen or ibuprofen, but the current headache did not improve with medication. With regards to his eye symptoms, he states his right eye was turned inward and was unable to look outward. He's had double vision when using both eyes, and monocular vision is normal. Diplopia is worse on his right gaze. He has no nausea, vomiting, weakness, numbness, tingling, eye pain, floaters, or vision loss.
All right. Now, given the history and with the presenting headache and the eye problems, now what would you be your localization and the differentials?
Let's have Gerardo go first.
Okay, thank you, Dr. Shi. And yeah, well, now that this story has changed, has changed a little bit my perspective, because in my first intervention I claimed that it could be a case of intracranial hypertension, so that was my main hypothesis. Now that I hear that this headache is sort of like remitting pattern, and it also has some elements of that appear to be increasing with the horizontal position. I think I can increase my probability of this being a diplopia that is triggered by a bilateral insult to the abducens nerve due to intracranial hypertension. At least that's from my perspective, from a pre-grad perspective. But yeah, I think that can explain that could explain the clinical picture here. But I'm really curious to know whether Dr. Shi's thoughts about this. So yeah, please.
Yes, I agree with Gerardo. I'm struck by the positionality, and that's one of the other headache features that I really like to ask every patient. So it sounds like this patient's headache is worse at nighttime, or like worse when sleeping, and is woken. The patient is awoken while sleeping with this severe headache. So I am thinking about increased intracranial pressure. Like Gerardo is saying that people can have like a false localizing sign from increased intracranial pressure would be stretch on the abducens nerve.
Oh, sorry, is it me or Dr. Shi's just froze?
I think Dr. Shi, I think you're frozen.
Yeah,
Oh, okay.
I think we can wait for a while. Hi, Dr. Shi, can you hear us?
Oh, I think while we wait for Dr. Shi's, we can read some of the comments in the
Oh, I
chat.
think she's back.
Oh,
I'm so
okay.
sorry.
Oh,
I hope this doesn't keep happening. It's saying my internet is not stable, but I feel like this is a good spot in my house for internet right now. I'm so sorry.
Yeah,
Um,
don't worry about that.
I
Yeah.
hope it doesn't keep
Okay.
happening. But I was saying that when somebody, so this patient having worsened binocular diplopia, when they're looking to the right, it makes me think that they could have a right cranial nerve 6 deficit or lateral rectus deficit. Since there's like headache pain going on, I'm thinking more about the nerves than I am about the muscle. So it could be like a right cranial nerve 6 issue, which like we're saying, could be false localizing sign from increased intracranial pressure, or could be some type of meningeal irritation or some structural issue causing a right cranial nerve 6 problem. Or it could be a left cranial nerve 3 problem, where the left cranial nerve 3, when somebody has cranial nerve 3 deficit, like in the left eye, the eye tends to be down and out and has difficulty with adduction. So when you're trying to look to the right, if somebody has a left cranial nerve 3 problem, their left eye is not going to adduct as well, and that would cause ocular misalignment so that the double vision is worse when they're looking to the right.
What a great discussion. And so, Dr. Helen Shi and Gerardo, what would be your first physical signs or neurological signs to look for these patients?
Oh, should I go first? Yeah, I think that something that we can assess a patient that we are worrying about intracranial hypertension would be to look at the eyes, and specifically to do a fundoscopy, because through a fundoscopy we can see if there are signs of intracranial hypertension that can increase our pretest probability for that. And yeah, I think that that's what concerns me the most. And I also want to, if I was seeing this patient in person, I would like to see the osteosarcoma if it's feasible. If it's not, then obviously we couldn't see that. But I just want to know if there are signs of dissemination of the cancer, because that can be a sign that this is not a localized issue. We know that the osteosarcomas tend to have a lot of metastasis, but in early stages, it is a localized process. So I'd like to know if this patient also has some signs of metastasis, of distant metastasis, or lymph node involvement that can indicate that this patient is having metastatic osteosarcoma. And yes, that's what I would look for, but I'm curious to know what Dr. Shi would say.
I absolutely agree with Gerardo. The first exam finding that I would look for is how are their optic discs? Do they have sharp, crisp optic nerves? Or is their optic nerve, like optic disc blurring, or edema or elevation that indicates that there is increased intracranial pressure? And like I'm seeing from the chat that multiple people have spoken up about concern for metastasis, and that's exactly what we're talking about, that when somebody has metastases, or when somebody presents with a headache and what we're thinking is a cranial nerve deficit, we're definitely thinking, is there a structural cause to those symptoms? And that could be meningeal irritation from like leptomeningeal carcinomatosis from spread of that metastasis, or spread of that cancer as metastases, or and or causing increased intracranial pressure, because when we have metastases to the leptomeningeal space, oftentimes CSF reabsorption in the flow of CSF is not normal, and so people develop increased pressure, or there's like proteinaceous, cellular elements that are in the spinal fluid that increase the pressure. Going back to additional exam findings, I would want to do a detailed eye exam. So in addition to a fundoscopic exam, I'd want to know what their visual acuity is, how their pupils react, if there's a relevant relative afferent pupillary defect, and paying special attention to their extraocular movements. And then also doing a good cranial nerve exam, because when we're thinking about leptomeningeal disease, whether it's from spread of cancer or something, like anything that's in the leptomeningeal space, like blood products or something. Well, I guess let's say it's like any of our cranial nerves could be affected, but let's taking a step back to talking about leptomeningeal carcinomatosis, that there are certain cranial nerves that are more likely to be affected. And in fact, the vestibulocochlear nerve, so cranial nerve 8, is a very commonly affected a cranial nerve from leptomeningeal carcinomatosis. So I always do like a Weber and Renee test and ask the patient about any hearing changes. And then it's important to test their trigeminal nerve distribution, V1, V2, V3 with pinprick and not just fine touch. Also important to look for any subtle signs of a facial palsy. So of one eye, maybe there's just slightly decreased elevation of the eyebrow, or a slight droop of the face. And so I like to do a very detailed cranial nerve exam, and additionally, for the rest of like the motor and sensory reflex exam in the body, I would say that reflexes would be
Okay. We lost contact with her again. I think we can just wait for a while. Oh, hi, Dr. Shi.
I'm sorry about that. I finished what I was saying, but I'm going to log in on my phone too, so I don't keep leaving you all. I'm so sorry.
Right. All right. Thank you all for your great discussion. Sarah, do you still have like any other history to talk? And then you can go continue the physical examinations findings.
Okay, you'd like me to do both? I have one medical history and like drugs aliquot, and I also have a separate physical exam history. Do you want me to do both at the same time?
Yeah, sure. You can go ahead.
Okay, so medical history and medications. He's got hyperlipidemia, for which he takes atorvastatin. He's got GERD, for which he takes omeprazole. He takes a daily aspirin. He takes cetirizine. And then no drug allergies. In surgical history, he does have a history of osteosarcoma and is status post BKA and has no complications. Family history, father with CAD and type 2 diabetes and renal cancer and prostate cancer, but has no family history of autoimmune conditions. Social history, he has a 15.6 pack year smoking history, does not drink any alcohol, is married and monogamous, and is a retired police officer. And would you like to go on to physical exam, or do you want to stop at that aliquot?
Oh, okay. So I will stop here for a while, and I would like to ask Dr. Shi and Gerardo about this additional history where he has like what strike in my mind is like social history. He has a short smoking for a long time, and also he has like family history of cancer. So do you also have any other things in your mind regarding this with your differentials?
Should I go first? Yes, I do think that in a cancer patient, it is very important to ask for a history of other types of cancers, not necessarily the same cancer that the patient has, and because that can be a source of genetic counseling, which is very important these days. So I think in the family history, that's what struck me the most, that the father had prostate cancer, although we don't know if it is syndromic or if it is sporadic. But I just wanted to mention that big part that I think genetic counseling is very important. And also regarding the social history, I think that 15.6 pack year smoking history, it's a lot of it's a lot for a patient to increase the risk of having a neoplasm, which is something that is general for all neoplasms. But I don't know the specific relationship between cigarettes and the anososarcoma, but I think that it is up there with all the other types of cancers. And yeah, regarding the past medical history, we already knew the osteosarcoma and the hypertension, and I think hyperlipidemia and GERD and occasional headaches doesn't really give me a lot of information, because those conditions are very common in the population. So we should really be very cautious interpreting that. But apart from that, I don't have anything more to add, and I'm very curious once again to know what are Dr. Shi's thoughts about this case.
I agree with you. I'm not so impressed by the rest of his past medical history, but I am concerned about his smoking history and his family history. And he may have a different malignancy that this could be the first presentation for. Osteosarcoma, I don't think I've ever seen it metastasize to the left meningeal space or the central nervous system, like parenchymal disease or spinal cord disease. But I'm open-minded to it. I'd have to learn more about it.
Yeah.
Great.
Okay. So yeah. So Sarah, you can go ahead with the physical examination findings.
Great. So physical exam, general or vitals. His blood pressure is 184/78, heart rate of 63, temperature of 36.7 or 98.1 Fahrenheit, respiration rate of 15, 95% oxygen saturation, and BMI of 52. His physical exam, general and no acute distress, HEENT, normocephalic atraumatic with no scleral icterus and moist mucous membranes. Respiration rate is normal, work of breathing is normal. Extremities, he has significant bilateral leg edema and then has a right BKA. Skin is warm and dry. And then neuro exam. We've talked a little bit about what you would be interested in knowing about. So we can either stop here or I can continue going on.
Keep going.
Okay. So mental status, he's alert and oriented ×4. His language is fluent without aphasia. Normal attention span. Cranial nerves, pupils equal, round, and reactive to light. Visual fields fold to confrontation. He does have an abduction deficit of the right eye. Sensation to light touch is preserved in V1 to V3. Face is symmetric. Hearing intact to conversation. And has full trapezius strength. Symmetric palate elevation. Tongue is midline. No dysarthria. Motor is normal. Normal bulk and tone. Intact strength throughout. Sensation is intact to light touch. Pinprick not assessed. Reflex is 2+ in the arms. And I do have a video, so I'm going to share my screen. See it okay?
Yep, we see it. Ooh.
Okay, I'll replay it once more. Sorry, it's kind of in the way. I don't know if I can. Okay. Do you want to see it one more time or is that okay? Okay.
That was fine.
All right, given this physical findings, now what will be your localization and management approach?
Gerardo can go first.
Oh, thank you, Dr. Shi. And yeah, well, I think that from the video that I just saw, I saw that there was an impairment with the abduction of the right eye, just as was reported. And I tried to look if there was also another component of the misalignment of the eyes, not just in the horizontal plane, but we also look for example, intorsion or extorsion, and that could mean a compromise of the oblique muscles, specifically the superior oblique muscle, because that is the only one that is only innervated by the trochlear nerve. And yeah, that from what I've seen, I've only been able to identify that. I'm not really sure if there is another deficit. Please, Dr. Shi, correct me if I'm wrong. But then apart from that, there are, since we were discussing previously about intracranial hypertension causing bilateral insult to the bilateral non-localizing insult to the abducens nerve, then I think that this picture isn't really screaming to me intracranial hypertension, just because it's just in one eye that changes my perspective. But I'm curious to know what are your thoughts on this, Dr. Shi?
Yes, I agree that this abduction deficit of the right eye is not subtle. Like he cannot cross past midline in the right eye, like very obvious. And I would be surprised if he doesn't have binocular diplopia while looking straight ahead, especially looking at things far away. And so when people like when any of us look at something far away, like when we're driving or like looking at a landscape or looking across the room, our eyes do abduct very slightly, like both eyes abduct very slightly so that we can look at things far away. And when we're looking at things close up, our eyes accommodate. And when somebody has an abduction deficit, they're going to notice it more when they're looking at things far away, and also when they're looking at things on the same side as their abduction deficit. But his abduction deficit is like really severe. It's like, I mean, it looks like it's like the most severe it could possibly be. Like, it can't be any worse than that. And for that, I agree with Gerardo that probably this is not because of increased intracranial pressure, because we would expect it on the other side too at this point, given how severe the right abduction deficit is. So I am thinking that maybe there's something coding the right cranial nerve 6 nerve, nerve, or there could be a fascicular issue or a nuclear issue, although typically when we're having a nuclear or fascicular issue of a cranial nerve, other, that's like very prime real estate in the brainstem, like at the level of the pons. And so normally we'd have other like long tract signs or cranial nerves affected. And so having like contralateral weakness or ipsilateral cranial nerve 7. The facial colliculus is a location in the dorsal pons that houses both the cranial nerve 7 nucleus and the cranial nerve 6 nucleus, with the fascicles of both kind of intertwining. And so when somebody has a nuclear 6 or fascicular 6, so fascicular meaning the cranial nerve as it's still in the brainstem after it's after the nucleus, but before it exits out of the brainstem, we call that the fascicle. And so when we have a nuclear cranial nerve 6 or a fascicular cranial nerve 6, normally it would affect other really important nearby cranial nerves, like cranial nerve 7 on the same side, or cortical spinal tract fibers, so causing like contralateral hemiparesis. It doesn't sound like he has any of those on exam. So I'm really thinking that there's something going on after cranial nerve 6 has exited out of the pons, and then like the whole pathway of cranial nerve 6, which includes like going along, like it goes along like the petrous segment of the temporal bone. It also enters the cavernous sinus. We're not hearing other cavernous sinus problems right now, so that would be cranial nerves 3, 4, V1, V2, and 6. Or there are other things in the cavernous sinus, like there's a lot of venous blood. That's like what the cavernous sinus is. And so like a cavernous sinus thrombosis, if he has like hypercoagulable state from his cancer or some other reason, you can have a cavernous sinus thrombosis. Normally you'd affect other cranial, like, 3, 4, V1, V2, in addition to 6, and not just like 6 in isolation. But that's something to think about. Also, the cavernous segment of the internal carotid artery travels through the cavernous sinus. And so somebody who has a cavernous sinus, who has a internal carotid artery aneurysm of the cavernous segment, an aneurysm could grow, and cranial nerve 6 is right next to that internal carotid artery, like the cavernous segment of the internal carotid artery. And so that would be like, of all the cranial nerves to be affected by an aneurysm in that location, it would be cranial nerve 6. Although typically that's not painful, and even a rupture, if it were to rupture, I'd expect other cranial nerves in the cavernous sinus to be affected. And then cranial nerve 6 then travels through the orbital apex and the superior orbital fissure to then innervate the lateral rectus. And so I'm wondering about that pathway. But with him having headache, that's worse when he's supine, I'm thinking mostly about the leptomeningeal space with cranial nerve 6 after it's exited out of the pons.
Given all these differential, what would be your first investigation to order to get your diagnosis?
Gerardo, go ahead.
Oh yeah, the first investigation, yeah, that's actually something that it's really interesting to me, because when I remember studying for the cranial nerve 6 palsy, I remember that one of the things that we have to think about is the non-localizing signs of the intracranial hypertension, but also the anatomic approach for every cranial nerve. It's very important. So I'm really glad that Dr. Shi did a really comprehensive approach of the trajectory of the abducens nerve, but it is actually a very hard to assess in its singularity in the brain, just because it is inside the head, right? It is a cranial nerve. So just to I think now is the time that we could order some special tests like a CT or MRI, But apart from that, I would say that in the cranial nerve 6 palsy that I agree with Dr. Shi, this may be a peripheral problem rather than a central problem, just because the close proximity of the abducens nuclei in the pons to specifically the seventh nerve, right? Because in Spanish we call it la rodilla del nervio abducens, which is basically the structure that surrounds because the abducens nuclei, it forms this structure that is called the rodilla, which covers the facial nuclei, which is something, some nuances of the anatomics of the pons that I really like, and I really like to teach to my to younger students in medicine now that I'm in 6th year. And yeah, that's something to think about, but also I would prioritize peripheral causes, meaning the nerve itself. I know that the abducens nerve, for example, as Dr. Shi said, is it's in the midline rather in the more lateral aspect of the cavernous sinus. So it could be first affected if an aneurysm were to happen. And for that to be investigated, we will have to order an angiography. So apart from a normal CT of the head, I would order also an angiography. And also, just because we were thinking about a possible metastasis, which has not yet been ruled out, I would order also a head CT with contrast, and also I think I would wait a little bit for the MRI, because at least here in Peru, due to limited resources, we don't really order MRI. We just order it if it is needed. So right now, I think the first study that I want to do to this patient is a CT. And yeah, those are my thoughts. I'm really curious to know Dr. Shi's thoughts on this.
Um, yeah, so this is a patient who would get a CT scan without contrast in the emergency department, just to make sure that there's no obvious structural problem like hydrocephalus or cerebral edema from some structural compromise, or blood in the subarachnoid space, or blood anywhere. And so our typical algorithm would be to then go ahead and order an MRI brain with and without contrast, and also an MRI orbits with and without contrast. That way we can visualize the nerves as they are coursing through to the orbits, and also looking closely at the cavernous sinus and the orbital apex, superior orbital fissure. If this patient had optic disc edema, then I would also order an MR venogram with and without contrast, like MR venogram of the head with and without contrast, just to make sure that all the dural venous sinuses, including the cavernous sinus, is nice and patent without any thromboses. Sarah, I don't recall if you said the fundoscopic exam was normal.
I didn't give you a fundoscopic exam, but I can tell you that it was normal.
Okay, so this would be a patient that we'd probably just do an MRI brain and orbits with and without contrast.
We are pretty sure we'll see like any structural lesions or things when we get the imaging. But before we go to that, in our chat, we see some discussions, like Ethan said, with given hyperacuity history, he would still like have stroke in his mind, especially like dorsal pons and midbrain, and also like acute closure glaucoma can also explain frontal headache. So how will you also like differentiate with these differentials?
Oh, yes. So when I read the answer from Ethan, I thought that it was something we should consider it, because this is this is a problem that we are not really sure if it is a localizing problem or a non-localizing problem or a diffuse process. But now that we have a clear insult to the right abducens nerve, then we should first ask one of the basic questions in neurology: is it central or is it peripheral? And for me, I think that this is more of a peripheral picture rather than a central picture, but I'm not really I'm not really sure if the central causes could be ruled out. If we ruled the central causes out, then obviously a stroke, it's out also. So far, the only sign that we have seen that could be an indicator of a nervous system problem would be the decreased abduction and obviously the headache and clinically the double vision. But aside from that, since this is a patient, we should see it as a whole. Then if this could not be ruled out by an imaging study, I'm really curious to know what other studies would be performed to really indicate to really search for an answer in this patient, because even though I think it's rare from what I've read in the when I was studying for this of cranial nerve 6 pulses specifically, it's rare that there is an insult to just the abducens nerve, and it being a case of presenting with headache, and also in a patient that has cancer. I think that the first thing that I said, it's also important now for me because and what I said is, is there a link between the cancer and the clinical presentation here? And I think if there is a link, then the only possible explanation would be metastasis. But for metastasis to just present with an insult to just one nerve, I think it's really rare. So I'm really curious to know more about this patient from see, yeah, I'm really curious to know more about this patient and also to know more about Dr. Shi's thoughts on this.
So to my thought about stroke would be that it would be really unlikely to have a stroke that causes isolated cranial nerve 6 deficit, and so that's not high on my differential. I also think that it could be reasonable to do a CT angiogram. It probably wouldn't be the first test that I would do, but if the MRI brain and orbits were unremarkable, then I would do a CT angiogram to look at that carotid in the cavernous segment. But I think that a stroke would be really unlikely. I mean, certainly in a 4.5 hour window of their last known normal and they have a new cranial nerve 6 deficit, we would definitely assess the patient and do a detailed neurological exam to see if there are other localizing features to that, like right dorsal pontine area. I guess if I had a story that a patient had come with I don't know, it would be really tough. I mean, it would definitely be shared decision making like it would be unusual for somebody to have just an isolated like cranial nerve 6 deficit causing to the brainstem. Certainly people can have ischemic cranial nerve palsy, ischemia to the nerve itself. And so that would be, typically that would be diabetic, other vascular risks, including smoking, hypertension, hyperlipidemia, could be causes for an ischemia to the nerve. but with this patient having recurrent headache episodes, it's like more going on than isolated.
All right, I think Dr. Shi is back. So we can go for our investigation, like any imagings. Sarah, please go ahead.
I'll start with labs and then move on to imaging. Basic labs, white blood cell count of 9.4, hemoglobin of 14.2, hematocrit of 43.1, MCV of 93.1, platelets 270, sodium 137, potassium 4.8, fluoride of 99, bicarb 27, EUN of 17, creatinine of 0.98, glucose of 157, AST of 26, ALT of 34, ALP of 81, A1C of 6.2%, UA with blood but otherwise unremarkable, LDL of 156 with a normal HDL and normal triglyceride, B12 of 171, which is low, magnesium of 2.1, which is normal, cortisol of 1.1, which is very low, TSH, which was normal, prolactin, which was normal, PT and INR were normal, ESR of 36, which is a bit elevated, and CRP of 4, which is normal, and TSH was normal. And then ophthalmology exam, including fundoscopy and pressures were normal.
Dr. Shi and Gerardo, is there any striking features that you want to talk about with these lab reports?
Yes, I think that Dr. Shi mentioned in her intervention that one of the causes of cranial nerve 6 palsy could be, for example, diabetes. And we know that diabetes, if it affects the cranial nerves, the cranial nerves that are affected the most are the cranial nerve 3 and the cranial nerve 6. Although I would expect bilateral involvement, although that is just a guess. I haven't seen it in actual evidence, scientific evidence, I'm meaning. But yeah, the glucose here, it seems elevated, but this is just a picture of the patient. The glucose in itself, we have to perform a glucose tolerance test. If that were to be abnormal, then we could suspect that this is a patient that is that may have diabetes. But for diabetes to have a debut, its debut at 60, because he hasn't been diagnosed previously. I think it is unlikely, and the A1C level of 6.2, which is a little bit high, but not too high to think that this is a chronic problem, that it may be causing a isolated right cranial nerve 6 palsy. Then well, the other results which are the low B12 and the cortisol of 1.1, I think if you could answer to me, please, this level of cortisol according to the normal lab values, or actually, which are the normal lab values of the lab that it was taken? Please, if you could answer that for me. So cortisol, it's really low, right?
Very low.
Okay. Okay. So for cortisol to be really low, it adds another problem to this case, because now we are facing hypercortisolemia, which is not a neurological problem, but we also have to look at this, because obviously this is a patient that is not only presenting with an isolated abducens nerve palsy, which he is also presenting with headaches, double vision, and the headaches increase when the patient is in the horizontal position. So for a patient to have hypocortisolemia, it is actually, we have to establish first which part of the axis is damaged. For example, are the adrenal glands damaged? Is the pituitary damaged? Is the hypothalamus damaged? But obviously, if we are in a neurology case discussion, this may bias us towards more nervous system uh, localization, which actually it's a little tricky there to think about this, but just to entertain the possibility of this being an adrenal gland problem, then I think that, for example, metastasis can also happen to the adrenal glands, but that those metastases tend to be from another source rather than not osteosarcoma. They tend to be from the lung. I haven't heard about metastasis from osteosarcoma to the adrenal glands, but I'm happy to learn more about that. And also the low B12, well, in a geriatric patient, the low B12 could be explained due to, for example, lack of intake. But lack of intake in a patient that is from the US, I think it's unlikely because just because the uh, it's a high income country where you will have access to good nutrition, but um, I it also could be due to other problems that, for example, if this patient were to have a history of, for example, problems in the stomach that could imply that this patient is not absorbing well B12 or problems in the GI tract in general, then that could make me think about a possible cause. Um, and yes, but now that we have discussed the medical problems, now I think we can entertain the more rare ones, which could be in the central nervous system. But we actually not central nervous system, in the nervous system, because now as we have discussed previously, the central nervous system may not be involved. But if we are thinking about the anatomics of the abducens nerve, and now that it has said that it is emitted from the pons, and then it does a really long trajectory and in these really nuanced spaces, anatomic spaces. I just don't want to go into a lot of detail, but it is really in close proximity to some structures that are really important for the neuroendocrine system, which are the hypothalamus and the hypophysis. So I think that a hypothesis of problems in the pituitary could be entertained, just because problems in the pituitary are just more common than problems in the hypothalamus. But since we are discussing pituitary, which is also a structure that is really in close proximity to the cavernous sinus, which is the structure that the abducens nerve traverses, then this could be a case of a mass process involving the pituitary that is also damaging the abducens nerve. And for that to be the case, I think that the most common cause would be a pituitary mass, that is causing the adrenal insufficiency that we just discussed. And the adrenal insufficiency that we just discussed, now we can entertain the hypothesis that this is a secondary cause of hypercortisolemia, and the secondary cause of hypercortisolemia would be this mass that is causing a compression of the pituitary, and it is not producing enough ACTH, which can lead to adrenal insufficiency. And adrenal insufficiency causing this clinical picture, I just wouldn't think, it's not my first thought to think about hypocortisolemia causing this, but I think this is a really interesting case because it allowed us to discuss a lot of anatomics and a lot of differential diagnosis. I am not sure if this is the final diagnosis, but I think this was a really rich case because even though cranial nerve 6 palsy, it's very it's rare to just find it in isolation. It allowed us to further discuss anatomics and also discuss medical problems that coexist with neurological problems because they are all problems that affect the body, right? So I think, well, those are my thoughts, but I'm really curious to know what are Dr. Shi's thoughts on this. Yeah.
I absolutely agree with Gerardo that the hypocortisol level is very striking and unusual. Also, like strange that he's hypertensive with low cortisol. I'm not sure like why that is. I agree with Gerardo that this case overall wasn't screaming a low cortisol state. Typically, when people are in a low cortisol state, they're like they have, if with neurological symptoms, oftentimes they have like altered mental status, and they're hypotensive. But in this case, knowing that the cortisol level is low and knowing this person has a right cranial nerve 6 palsy and has a severe headache, it seems like recurrent, or at least like 2 episodes of severe headache. I am concerned about something going on with the pituitary gland. And the I see in the chat other people have mentioned pituitary apoplexy, which is high on my differential. That typically when somebody has a pituitary adenoma, macroadenoma, normally it's not like sudden severe pain. It could be, but typically, well, I guess this patient has been having chronic headaches, and with maybe they have had a pituitary adenoma, macroadenoma that's been growing, and then that is a risk factor to having pituitary apoplexy. And maybe one day it, like the day he presented, and maybe 10 days ago as well, it just bled, and that is what caused the cranial nerve 6 deficit on the day that he presented. It's hard to catch that on a non-contrasted head CT. Looking at the like suprasellar area, there's just a lot of bone around there, and so it can be hard to catch on a CT scan. But certainly with an MRI of the brain and orbits, you'd probably catch it. But really, an MRI of the pituitary would be most helpful with and without contrast. And so I would add that to our testing.
Yeah, I completely agree. And I just want to mention one thing extra, if you allow me, please, that this patient also had a really high blood pressure. And the really high blood pressure, I think it was overlooked first for me just because I may be biased from my neurological from my neurological interest. But that blood pressure should also raise concerns for us because low cortisol and high blood pressure doesn't really go together, right? Because we expect that from low cortisol, there's a lower expression of the alpha-1 receptors, and the lower expression of alpha-1 receptors should cause hypotension rather than hypertension. But since this is a neurological process, this may be a reaction from the body due to a mass processes or an insult that tends to be, I think the most common insults that tend to cause hypertension are ischemic issues, like, for example, the pituitary apoplexy that was discussed. But I think it's worth mentioning just because I think it was a little bit overlooked. So I just wanted to add that. And yeah, I don't know if there's Dr. Shi, you want anything more to add on that, or should we get more information about the case?
I think that's a really interesting. Ooh, sorry, I am.
Okay, sorry about that. I have too many things open. So I think that's a really interesting hypothesis because I was trying to put it together, like, why does this person have hypertension with hypocortisolemia? And I think that like cerebral autoregulation, like what you're suggesting, is one possibility. Um, I do wonder with pituitary apoplexy if people become hypertensive from the apoplexy, or yeah, like what comes first? Like they have apoplexy and then they, their cortisol drops because of the ACTH issue, and then I would still think that people are mostly hypotensive at that point, but I'm not certain. Certainly with ischemic stroke to the brain tissue, like brain parenchyma, people become hypertensive. But that's not something that I'm positive about with pituitary apoplexy. Also interesting that this patient had no visual field deficits, which typically when people have a pituitary issue, the classic teaching is bitemporal hemianopia. And so they would have deficits, testing each eye individually, of course, of having like, when you cover the right eye and you're testing the left eye, they have a temporal field deficit. And then when you're testing the right eye, they have a temporal field deficit as well, which when you test both eyes open, you could miss it. I wonder if he had detailed visual field testing. That would really localize this well to the pituitary if there was bitemporal hemianopia in addition to the cranial nerve 6 deficit.
All right, now the case is really interesting. We have a lot of debates. Thinking just primary localizing like neurology, primary structural lesions, and now it has like all the endocrine and things like that. So yeah, please take us, Sarah. Is there any imaging to show or any other investigation results?
I have lots of imaging, and I can either show the images or give the results to select ones and then show select ones, whatever people are feeling like for time. Which things would you like to see, Dr. Shi?
Why don't you tell us? Oh shoot, this is open again. Okay.
Why don't you tell us the results of the scans and then show us the most pertinent one?
Okay, that sounds like a great plan. So non-contrast CT, no acute findings, no evidence of intracranial hemorrhage, masses, mass effect, midline shift, or ventricular dilation. CTA, head with IV contrast, no convincing evidence of a paracellular or cellular vascular abnormality, no large vessel occlusion, diffusely diminutive caliber of ACAA1, which is favored to be of congenital etiology, and then fenestration of the A1 segment, which is an anatomic variant, multifocal atherosclerotic disease throughout the head with moderate narrowing of the MCA, M2 superior division and left distal PCA. And then please see recent CT face and outside MRI for evaluation of non-vascular findings. So we have a CT maxillofacial without IV contrast, T1 hyperintense reniform signal abnormality in the right lateral aspect of the sella, extending into the cavernous sinus, blood products present, and then osseous dehiscence along the right posterolateral aspect of the sphenoid sinus wall, which directly overlies the area of the sellar/cavernous sinus hemorrhage. And then the MRR brain from outside hospital is the one with the most obvious changes. So I'm going to bring that up and then share my screen. I think I correctly have it in anonymous. So image window. Let's make sure that this is okay. So we have a coronal slice, and we have a nice radiological sign here of our mass. So going back and forth over that. Yeah, so this is the pituitary post on MRI. Do you want to see any axial slices, or do you want to stay with the coronal slices?
Yeah, please show.
Axial T1. So yeah, it's definitely easier to see on the coronal. Yeah, and Dr. Shi, do you have a preferred visualization method for pituitary tumors?
Looking at the pituitary sequences is the most helpful. So that coronal pituitary sequence is really good, and that it's post-contrasted as well. But if there's an axial like an axial pituitary, like here, yeah, in the lower half, it's all these pituitary sequences. I think that like those are pituitary posts. Yeah, maybe this like T1 pituitary post, maybe it has thin slices through the pituitary. It can be, I was saying that like non-contrasted head CT can be easy to miss a pituitary lesion. But even an MRI brain that's not pituitary protocol can also be easy to miss a pituitary lesion. And so in a patient with a high suspicion for a pituitary problem, we'll send them back through the scanner if a pituitary protocol was not obtained. And so I see that these pituitary sequences they seem like they're all post-contrast, which is nice. It's very nice to look at them with post-contrast. Oh, I guess there's pre-contrasted ones too, like
But
maybe.
we don't have axial, so
Yeah, that's okay. Coronals are really best for looking at the like coronals and sagittals. But this is this is like a T2 or a T1. What is this? A T1 pre-contrast. And so we can see that there's some T1 hyperintensity in that right-sided pituitary, like extracellular lesion that it could indicate that that's blood product. So when we look at images on T1 and T2, non-contrasted, if it's bright on T1 and bright on T2, then that could be subacute, like most commonly that is subacute blood. And so it does make us think that this thing is bleeding. Are you able to tell us like what it is? Like, is this an osteosarcoma metastasis, or this person is just, unlucky, has a pituitary macroadenoma that then bled?
Oh, I'm gonna give you all the information.
I will. Can I make a question previously? Just because this is really interesting for me, because that localization, I just haven't seen that before, and I think that this localization it's really close to what a medical student that's my friend that wants to do neurosurgery talks a lot about this. That's why I've learned a lot from him, from his teachings from cranial nerves anatomy. So I remember the differential diagnosis that he told me about this localization specifically, which in the central part of the brain, if it is involved in the cellular part of the cellular part, it can be chondroma, it can be also meningioma, and it can also be chordoma. But those three differentials that he told me obviously go this goes way beyond that, because this is a case of a patient with osteosarcoma. And from what I'm seeing, I'm no expert on imaging, but from what I'm seeing, I don't think this is the case of any of those masses, but rather it may be a mass. It may be a mass, but this is more likely blood products as Dr. Shi said. And apart from that, I am a little bit speechless right now. So I will please continue showing us more imaging. Or Dr. Shi, do you have any more to add to what I just said?
Well, if I were involved in this case, this patient would be emergently taken to the operating room to remove blood products and also resect that lesion, because blood in the pituitary is, like in that pituitary suprasellar region, is not good, and it is a neurosurgical emergency. And so this patient will go to the OR. I was just asking Sarah if you could like tell us the answer.
Yeah. Yeah. I think our next aliquot, I think, I had some endocrine labs, but I can give the endocrine labs and the final aliquot if people want to go directly to that.
I think for the sake of time, that's good.
Yeah. Okay. That sounds good. So after that really low cortisol and then finding this lesion in the pituitary, further endocrine workup, he has a GH of 1.03, a prolactin of 10, ACTH of 25, an FSH of 6.5, LH of 3.9, and TSH, which was normal, as I mentioned. And then thyroid studies also normal. And then they did a somatomedin C, which is downstream of GH, and it was within normal limits yeah, and then his total testosterone and free testosterone were low. And then he was, after advanced imaging, neurosurgery did schedule the patient for surgical management of the tumor and blood products. And on surgical pathology, fibrous tissue with bone and reactive changes, granulation tissue with chronic inflammation, hemosiderin deposition, focal neuroendocrine cells, but no diagnostic evidence of pituitary adenoma. So his final diagnosis, with all of the information that we have, a 60-year-old male with subacute progressive headache and binocular diplopia with an isolated cranial nerve 6 palsy, an imaging confirming diagnosis of pituitary tumor with apoplexy and extension into the cavernous sinus. After repeated visits to the hospital for pain and hemorrhage, the tumor was resected with neurosurgery and ENT assistance for approach. And then since resection, his vision has actually returned completely to baseline with no residual symptoms. So completely resolved with decompression.
Yeah, what a
Wonderful.
great case. Yeah.
Was
She and Gerardo,
lovely.
any takeaway points to share for this case?
Yes, I think for me it showed the power of clinical reasoning, just because the moment that we started to suspect this diagnosis was with the low cortisol, which is not something that we really link to neurological clinical reasoning. But I'm really happy that I just added this presentation to my differential diagnosis. So I think this is a really great case. And thank you for the opportunity to the clinical problem solvers for me to be able to discuss this. Thank you so much, Dr. Shi, also for co-discussing with me.
This is a wonderful case. I think that it really highlights the importance of knowing our neuroanatomy from the nucleus of where the cranial nerve and how it travels all the way until whatever muscle it innervates. And I think it's important for us to keep rarer things on the differential as well, including pituitary apoplexy. The I agree that this was an interesting case that a cortisol level was checked. I would say that like nothing, or not nothing, but like I would not have thought to check cortisol level in this patient who is hypertensive with a headache and a right cranial nerve 6 issue, it seems to me like we probably would have found the pituitary apoplexy between the MRI brain and orbits sequences in the MRI brain or of the MRIs, but certainly seeing one of those the hypothalamus pituitary labs abnormal really drew our attention to that area of the body. But I think we would have found it. It's just interesting that a cortisol level is checked. And I wonder from our internal medicine colleagues, endocrine colleagues, if something about the case before this cortisol level was checked made one want to get a cortisol level. But
I can
it
tell you.
sounds to me like this patient already had a working diagnosis in an outside hospital and was transferred to our hospital for tertiary management. And so probably that was why the cortisol was checked. It was after the fact, but we're getting to know this case kind of in a different sequence. But this was a really fantastic case. Thank you for sharing it with us.
Yeah, thank you. Sarah, do you have anything to talk with your case?
Yeah, so we were kind of mean and withheld very crucial information from the very beginning of the case, which was that he did have a known pituitary adenoma and had been receiving hydrocortisone replacement because he had had adrenal insufficiency secondary to his tumor. He hadn't been on it for some number of months prior to this presentation, and his tumor had been relatively quiet for a long time. Like he was diagnosed with the tumor 2 years prior to present. So crucial information that was left out, but you all still did incredible with the amount of information that you were given and were able to get to the diagnosis. Which honestly, very impressive. I was concerned about leaving it out.
Yeah, thank you all so much. Thank you, Sarah, for interesting case, and Dr. Shi for joining us, and Gerardo for discussing. We passed a little over like 7 p.m. Thank you all for joining today. What a great case. We will just close out for this discussion for today. Thank you all for joining.